This talk is sort of a continuation of the talks that they had at this meeting last year, which was huge because they had an international presence, and I think I had a fight with just about everybody that was talking there. And so that's what I'm famous for. We're going to talk today about the Occipitocervical fusion in patients who have Chiari, and especially in a subset of those patients who have joint hypermobility called EDS, Ehlers-Danlos syndrome. So this is a small subset of patients who have Chiari, but it was identified by the presence of the Chiari. Apropos of the talks you've heard this morning, I really hate the name Chiari. It's the worst thing that could have possibly happened to this mechanical distortion of the craniovertebral junction, and it just makes everybody so crazy. But when I got to the Chiari Institute 8 years ago, I knew about craniocervical instability or hypermobility. We'll talk about that this afternoon. But I was unaware of some of the symptoms and some of the signs that were found to exist in this subset of patients. So there are a group of patients, and many of them are treated at the Chiari Institute, that have Chiari. They have very significant joint hypermobility. They have dysautonomia, and I misspelled that. Oh, that's just terrible. And what I want to talk to you about is what I learned by epiphany. I go along accepting things that I thought I understood, and all of a sudden something happens and it explodes. Oh my God, that explains everything. So I want to talk to you about a little bit about four epiphanies that I've had. The first, and you'll see an example of it. But the first time that I became aware was, what do you do with a patient who comes to you? It was a less than a year-old baby who had been operated on by a very good neurosurgeon, and who had a very nice-looking result, but he was still sick. He had still a G-tube, and he still had. He was going to have to be ventilated, and it turned out that the Chiari, the distortion, had been caused by an abnormal degree of movement of the skull on the cervical spine. And that led to, over the next 10 years, 10 more of such patients. And the importance of the relationships of the bone to the brainstem in Chiari was born in me. The next step in that was Tom Millerot, my predecessor at the Chiari Institute, was the first to note that if your joints are hypermobile, your head can fall off, and that can actually cause, rather than be related to the Chiari, it actually can be causative. And the relationship of the hereditary diseases of connective tissue was born. And Fraser Henderson in 2013 deserves a tremendous amount of credit for recognizing that in these patients, it was expected that a very high percentage of them would have dysautonomia. And for me, dysautonomia at that time meant that you would have what we call orthostatic intolerance, so that when you got up, you got dizzy or you could fall and faint. They couldn't tolerate changes in temperature. They either had too much or too little perspiration. And they had problems of gut motility, and we've also learned a lot more about the immune system too. And Fraser Henderson in this just a few months ago, published his responses in the first two patients that he did, where he looked at dysautonomia as a result of fusion at the craniovertebral junction. All of those patients were children, and unfortunately my paper is still in preparation, but it's on its third draft now. So I think this is one of my favorite quotations. A scientific truth does not triumph by convincing its opponents and making them believe, but rather because its opponents eventually die, and a new generation grows up knowing these things and having an open mind. So the myth of Sisyphus, you know, he kept pushing the boulder up the hill, and it kept rolling down. And his job for eternity was to go back down and do it up again. So if at first you don't succeed, try again. So this drawing was of Brandon. This was done in 1996, was the patient I just told you about. And what we did, I went down to the autopsy and did some autopsy evaluations of the craniovertebral junction, as well as doing a study, and showed that this could be reduced. And, Dr. Menezes' algorithm for treating basilar invagination was true. And so what we found was that if you put the head back and kept it from falling off, then you can manage it. And this is true in a great number of, maybe I think it's probable that I just see an isolated group, or I'm sort of the catchment for these patients, but it's commonly related to Chiari I, and it's a mechanical problem of the skull, where the skull and the spine come together. So we are looking now we have an IRB approval to do a prospective outcome study on all the patients coming to the Chiari Institute. I'm now looking at the 94 patients between 2015 and 2017 that underwent craniocervical fusion in extension. They all had 5 millimeters of descent on the cerebellar tonsils. They all had abnormal measurements of OC stability. And the one that we're going to talk about mostly is the clivoaxial angle, which is the most sensitive to this. They all suffered from severe disabling pain and neck pain and headaches with mechanical worsening. The great test for this is how do they handle potholes? These patients will scream in cars when they go over because of the bouncing. And if their number one exercise is running, they probably don't have this because it hurts to run. They have to use the bike to get their exercise, or the other kinds of things. And we needed to, in order to intervene, it has to be significantly involving their quality of life. And a Karnofsky score is your quality of life, means that you're not doing a lot of the things that you must or should be doing. They all had they were given at least a month of a cervical collar to show that these things improved during that period of time. Just to be clear, the patients are suffering with pain. They're not we agree, they're not in imminent danger of death or severe neurologic deficits. Therefore, it's called functional neurosurgery. The threshold for accepting complications should be less if it's functional and not life-threatening difficulties. But patients' quality of life should be looked at. All patients had restriction of the quality of life due to the severe neck pain and headaches. And only the neurologic deficits that are related to the Chiari, like trouble with swallowing, numbness and weakness in the hands, these sorts of things were used as part of the discussion about whether or not to do the fusion. So this is the Millerot paper that I just talked about. And it changed everything, because these people are all, like you all are, I'm sure, at some point together online, and found the Chiari Institute. The problem is primarily that this joint hypermobility, which all of the Rakettes must have, almost everybody in Cirque du Soleil has, and I have a very high percentage of dancers and gymnasts in my practice because of the joint hypermobility problem. And fortunately, the people are skeptical because there's no genetic marker for EDS type 3, which is now called the joint hypermobility syndrome. So I always talk to patients. I mean, I think that we're lacking the skills to do that because there's no RVU for talking. at least not for us, and it really causes a problem. But I always sit across from the table or from the desk from the patients, and I can't tell you how high a percentage of the patients, by the time they finish talking to me, they're sitting there with their hands like this, holding the heads up. By the way, it gives me a chance to show you my grandchildren. So from 2013 to 2015, we did 94. 27 of those 94 had Chiari surgery, had been told that Chiari surgery was successful, and were still miserable. And of that 25, of that whole 94, we found 25 patients who had a clear-cut syndrome that I had never heard of, and didn't really exist, and still doesn't exist. But I now support Fraser Henderson's idea that this should be called the cervical medullary syndrome. And it involves severe dysautonomia. So what is this syndrome that we have found? Fainting, severe dizzy spells, we call postural instability. So when they stood up, their pulse would go more than 30 beats per minute higher. The ones that have had tilt table tests of cardiac function would show major increases in their pulse. They all had they had all been diagnosed with fibromyalgia, chronic fatigue. They all had chronic fatigue and interfered with their lives. The cognition, I think, is underestimated. They all had what they call brain fog, and all had difficulty with short-term memory. A lot of them had irritable bowel. They have inability to initiate the urinary stream. They had what they call gastroparesis. And more of them we found had mast cell activation syndrome with rashes and severe allergies. So because I didn't want to prejudge what the cause of this was and whether there would be any relationship, I called it Sarah syndrome because Sarah was the first patient that I saw with it. Or at least I saw many before that, but I only recognized it in her. So of this, in that 2-year period, we had 25 patients. 13 had prior diagnosis of Chiari, and 5 of them had previous posterior fossa decompressions. So 100% of the patients fit the criteria for joint hypermobility syndrome. 100% had postural instability with major drops in their blood pressure on assuming a stand, and major increase in their pulse waves, how many beats per minute they had. And those are the things that we used. 80% of them had irritable bowel, 68% had memory changes, 68% had confusional states, and 100% of these patients, of these 25 patients, had chronic fatigue. At least 2 patients had mast cell disease. So none of these things that are in the Sarah syndrome package were used to decide whether or not to operate on them. I want that very clear. So when you look at the outcomes, this is the radiographic outcomes. We would do an intraoperative reduction to make the CXA, which should be about 150. We did not operate on anybody with a CXA higher than 130. And the Grab Oaks lines, we've heard about it again. We had improvement in all of those 23 patients. The Karnofsky score improved in all as well, from a 20, which these are self-imposed numbers. The 20 is just close to death, and I don't. That's what the patient said. I don't think that was for sure, but all of them had a significant increase and improvement in their Karnofsky scores. Some of these things were really shocking, and I didn't believe it when I first saw these things. The pain was improved in 78% of the patients, so there was a major improvement in their pain and their quality of life. But over half of the patients said that their brain fogs and memory deficits had improved, and were in testing in the few patients that we've had, that was found to be true. Chronic fatigue in half the patients was improved, so they were able to access a real life and go back to exercising, go back to running. One of them went back to gymnastics, and I wasn't really thrilled about that. The dysautonomia, other is related to gastroparesis or irritable bowel or difficulty initiating urinary scream, and 2/3 of those patients got better, and essentially 2/3 of the patients with orthostatic intolerance had a major improvement, so they didn't faint when they stood up. I have to tell you that I was surprised, and this is a video. A lot of my pediatric neurosurgical colleagues are very skeptical of this because of how bad it is to have an occipital-cervical fusion and how it limits rotation. So I just asked
my mobility now.
her to show. Nobody has been unable. Every patient has been able to drive that were driving before. So and that's a big thing because of the fact you have to be able to see the side mirrors. And so it does cause some limitation, but it's not disabling. So we're still learning and continue to try to do better with a diagnosis and treatment of these complicated conditions, whether it be Chiari alone or Chiari with EDS or Chiari with Serra syndrome. And I believe that each patient has benefited from what has gone before, the patients who have been treated and reported and discussed before. As physicians, we have an obligation to get the information out to our colleagues, and that's why I'm so thankful for the ability to talk to you all in general. I think it's really important that we discuss these things. This is the example of what happens to the clivo-axial angle, and you can see that when the pressure comes off of the brainstem, which is being bent at a place where the vagus nerve nuclei are in the brainstem, and the vagus nerve nucleus is the prime mover in the cholinergic portion of the autonomic nervous system. I wanted to emphasize the need for the collar test to make sure that the patient actually is this hypermobility state. And we do intraoperative reduction, and you can just change the position of the head and it changes the angle at the clivo-axial angle. And we've made mistakes in the past without knowing it in terms of trying to do too much. When we started, we didn't know what the goal was, but now we realize that some of the patients who've had to have revisions. We used these skull screws up high, and some patients can't lie on a pillow properly with their Frankenstein pins. And so I've learned from Paolo Bolognese, who was the first that I knew of to be really embracing the use of condylar screws. Those purple places are the cranial condyles, which are underneath the skull. So therefore, all the screws and bolts can be under the muscle, so that they're not felt by the patients, and there are no more Frankenstein screws. What's really neat now with that is because I thought it was too dangerous, because the tongue, the nerve to the tongue goes right through there, as does the vertebral artery. But the use of neuronavigation intraoperatively has made all the difference in the world in the safety of doing this as a procedure. Disorders of the what I'm thinking, this is another sort of semi-epiphany, that I go into neurology because of the elegance of the neurologic exam. What you can tell by what the patient says and what the patient does and can't do, where it is in the brain or is in the central nervous system. And I never thought that the autonomic nervous system, that sweating and blood pressure and all of that, were a neurologic sign that may have a specific anatomic location. I think for me, that's the most exciting part of all of this, is that now we know, and we know that now the autonomic nervous system, we know it takes care of it controls the immune system. And we're now finding more and more that it also controls the ability to blood clotting and the coagulation profile. So the blood products are also controlled. Early results suggest the effect of problems at the foramen magnum and complex disorders of the autonomic nervous system at least in type 3 Ehlers-Danlos syndrome, is a treatable condition. And a Baton score, it should be easy to do a Baton score on everybody that has Chiari because it only takes 2 minutes. Now, the idea of the medieval cathedral architect. The architect who created the cathedral at Reims and the others knew that he would never live to see the completion. He would never lead because it took decades and maybe hundreds of years to complete these things. So this work that I'm doing is not finished and will never be finished in my lifetime. But I hope it continues. So we need to continue to evaluate the function of the autonomic nervous system and assess measurements of dysautonomia as part of a neurologic examination. I have real expectation that neuromodulation, such as vagal nerve stimulator, will make a big difference in the management of these conditions. And already they're treating chronic depression and rheumatoid arthritis patients with pain with vagal nerve stimulation. So I think that's where it goes. We need to replace skepticism with education, both in the patients and the medical community regarding these things. And I greatly appreciate the opportunity to talk to you. Thank you.